So we shall now go on to Dr. Ravindra's presentation, and he's going to be talking to us on premium IOL and MS-ICS. On to you, Doctor.
Am I visible on my slides?
Yes, slides.
Right. I'll give a very small slide presentation. Basically, an ideal IOL in cataract surgery should give good vision in all distances. That's ideal. Go back to natural way in which the eye was built without any complications or compromises. Profession versus industry. Industry wants to call all small advancements as like a native aspherical, blue blocker. They're all premium IOLs, but actually multifocals, accommodating lenses, and torics. These are the only three lenses which take you back into the normalcy. So it can be one of these four. We're all very familiar, but I would like to add that with modern designs, all these complications are very, very less. And I offer one of these lenses to everybody who has a need for them. And as recently as 2016, a survey said that 43% of cataracts.
Sir, your slides are not moving.
Okay, how about now?
No, they are not even full screen.
Sir, you have to stop sharing, then share again the slideshow. The PPT has been shared, so not the slideshow.
Okay, I'll go to the video. I don't know how to. Is that visible now?
Yes, sir.
Fine. So what I was trying to say is that only trifocals, bifocals, EDOFs, and continuous range of vision lenses and toric lenses are to be considered as premium lenses. All others are not. So let me save some time by showing a video. This is how I do a premium implantation. That's a steep axis. I'm sitting on the upper temporal quadrant. Maybe I've actually measured it where exactly I have to go. The initial entry is about half or even 1 millimeter away from the limbus through intact conjunctiva. And I go a little fast. I go through it. It's a 2.8 millimeter blade. It's a little longer incision when compared to a phaco standard, but it's very important to see that the configuration should be rectangular. It should not be smile or frown either in the anterior end or posterior end. The next is injection of viscoelastic into the anterior chamber. This is done under topical anesthesia. Here is the most important part, to keep the chamber deep. It may not be important here, but in a very complex case, it's extremely important. I entered the chamber with a cystotome itself by perforating the floor at the limbus. Then I'll do a rhexis of adequate size. And then I missed this point. Okay, now I enlarge it with a blunt blade. Again, you see that the lines anterior and posterior should be absolutely parallel to each other. Next will be enlargement of the anterior end. This is a recent thing. About 1 year ago, I started this because converting from this scleral incision to this incision, I had little more loss of endothelial cells, and that I discovered that it's because of tight anterior end. And after making enlargement, my the loss of endothelial cells is least, just like what I used to get at this thing. A good single point hydrodissection. Go a little fast. You're all familiar with this. And bisect the nucleus as it was shown by Dr. Mallikarjun and remove each piece. And it's, as you can see, it's a low pressure technique. The pressure is not increased. Patient has an IFIS. It's very floppy iris. You can see the pupil is constricting. And this is an irrigation aspiration Simcoe cannula. Both irrigation and aspiration are controlled by me so that I can control the depth of it. Subincisional cortex is aspirated by right and left Simcoe cannulas. And now you can, now I've slit the anterior end of the cartridge so that there's no disturbance to the lens at all when you're implanting it. This is an Indian IOL, Indian multifocal IOLs, which are as good, or I would rather say they can be better than imported ones, because these are designed, the ring size and spacing is designed for a smaller pupil when compared to any imported lens. And this has given excellent results to me. And these are available both in CRV and bifocal. Trifocal is my second priority, only for those people who have a need for that distance. If they don't have a need for distance, I do not want to divide them into a third area which is of no use to a person who is not using laptop or monitor. I would rather use a bifocal lens in such patients. Even in a mature cataract like this, it's very easy. You can do a rexis. It's a closed eye. I've stopped it halfway between to decompress the capsular bag. Now I'm enlarging and continuing it with the rexis forceps. Remove it, bisect it, and take it out of the eye. And then you can put, even in such cases, it's important to uh, include the lens thickness and AC depth in your calculation so that you have got on the spot, the results, especially mature cataract. It takes a lot of biometry efforts to get, because you can't do a optical biometry, you have to do an immersion biometry. And it's given very consistent results to me, even in such patients, to put a multifocal lens. So you go and put a multifocal lens, and that will be the end of surgery. Rexis is, of course, irregular. This is a case of posterior subcapsular cataract. My approach to posterior subcapsular cataract is a little different because it's a low pressure technique and a low flow technique. I'll just start with the next one. Okay. Yeah, that's a posterior subcapsular cataract, threatening to be a posterior capsular cataract. I've done a rexis. I do rotate the nucleus, epinucleus mass. It's a capsular separating hydrodissection. This step is very important to save the posterior capsule, and there's no lateral movements of the nucleus, epinucleus mass at all. It's brought into the anterior chamber, so the posterior capsule is not involved in the surgery at all, neither the zonules. Though it looked transparent and soft, it's a very hard nucleus. Needed a couple of strokes with the 25 gauge cannula, and so you can see the capsule is open there. If I pressurize the chamber now at this point of time, it's going to balloon backwards. All the pressure is going to go and hit there, and the capsule could break. So here in a low pressure technique where the AC is not deepened, it's normal depth, and the fluidics is very, very low, you can go and remove the cortical aspiration. Cortical aspiration is very easy because you've done a hydrodissection even in this patient, and then you go and put a multifocal lens. So my first priority lens today is a multifocal lens. I've implanted, usually I match the right eye and left eyes. Very rarely I have matched, multifocal lens in one eye, the bifocal lens in one eye, and the CRV lens in the other eye. But we'll try to buy from the same company instead of changing.
Sir, 1 minute remaining.
Fine. So that's the end of surgery. The eye does not need bandaging. The amount of astigmatism this tunnel produces is about 0.5 to 0.75, depends upon where I've entered it. This is pretty common. It should be straight. If when you're enlarging it, if the tunnel comes backwards at the edges, then you will have a lot of astigmatism. You'll have to modulate the tunnel in such a way that there is no cutting backwards at the ends of the tunnel. It should be straight, and the outside one also is straight. And this astigmatism can be very well controlled. And we do specular microscopic studies in every eye before surgery and after surgery a month later. And if there is a change, if there is a drop in specular, we know that what exactly is causing it. And that's one good reason to get a feedback continuously about your surgeries. Thank you.
Thank you very much, Dr. Ravindra. Amazing videos as usual. But seeing by your video, you're not going to answer the question. You have to answer these questions more relevant to a young surgeon. Now, how does this young surgeon decide to move into a premium IOL segment with the SICS wound, its variability, and the possibility of it being put on a stretch, especially in hard cataracts? What would your tip be for them?
Yeah, a very good question, Dr. Chitra. Amazingly, wonderful program. What I would recommend is consider every lens that you put as a premium lens.
Yes.
Target emmetropia in every case. Do everything that's possible to work up these patients preoperatively. As I said, excellent biometry has to be done either by you or by somebody else. Don't indent cornea when you're doing in a mature cataract. You'll have to depend upon immersion biometry. So that's pretty accurate. And then look at the wave of A and look at the K reading. K reading is very difficult in a mature cataract. So you'll have to trust the other eye and ask the patient to move the eye with a bright light pointing in the other eye. so that he can move and bring the cornea to the center and take K reading, not once, but twice, maybe even thrice by different people. So once you have the fixed K reading and axial length, then it's very easy. Analyze the results. You put same brand, don't change your brands. So take one brand and wherever multifocal is available, take the monofocal platform in the same company and keep doing it. And one of the most critical thing that you should do is you have to match the surgery with the post-operative results, SIA. SIA is the most important thing in a premium lens, and you should have a good control. Either you keep the SIA. I can create a zero SIA in this surgery by modulating the, the surgery, though the incision is as big as 5 or 6 millimeter. That's a possibility. And the other surgical skills has to be very good. So amount of trauma that you induce into the eye should be minimum, and you should target for a very clear cornea on the first post-op day. Cornea has to be clear on slit lamp. There should not be any striae, folds, edema. Maybe at the tunnel side, you'll have, at the tunnel bottom itself, you'll have some edema, but rest of the cornea, especially central cornea, has to be pristine. And then you analyze your results, at least 20-25 results. You know your astigmatism, you know your corneal level, you know your biometry. These are the three most important things. Then you are ready to implant your multifocal lenses.
But then the challenge in a hard cataract, unless you're doing a nuclear practice technique, is you have to increase the size of the rexus. And when we are talking of a premium IOL and size being very critical here, I suppose in those situations, all of them have to do a nuclear practice only.
Nuclear bisection within the capsular bag is a viability, but it's hazardous to the zonules if you are a beginner. Yes. It has to be prolapsed out through a 6 millimeter tunnel or through an 6 millimeter capsular rexus or with an oval capsular rexus. So it's a possibility. So you can have a 5 millimeter by 8 millimeter or 7 millimeter capsular rexus. Through that, any nucleus can come outside. You design the ovalness in such a way that the haptics are inserted at a place where the diameter of the rexus is smaller. So this is one tip that I can give in such patients where you need to put a multifocal lens or a toric lens in a case. Toric lens, it's ideal to have a circular rexus. If it's an oval rexus, it will rotate. So
before we go on to the next speaker, the last question I'm going to ask you is, when would you not do premium IOL and you're doing SICS? Has any contraindication?
Whenever the macula is off, we do an OCT in every case. We do endothelial count in every case. Wherever there is an endothelial problem, or if K is not, we do a pentacam in these patients preoperatively. If it's an asymmetric astigmatism, macular diseases, corneal decompensations, and very tough surgeries, where you expect that there'll be more turbidity or turbulence in the surgery, we would not put a multifocal lens.
Thank you very much, Dr. Ravindra. I think you answered all the questions.